Good morning from Miami Beach. It's Dr. John Bennett from Neurosurgical TV. We are honored to have the third webinar of the Chinese Neurosurgical Journal. And I'll introduce right away Wan Li Zhao, a neurosurgeon from Beijing. Welcome, Wan Li.
Hi, yeah, thank you, John. Okay, so shall we start?
Sure. So you want to introduce John, please?
Sure. Okay. Good evening, everyone all around the world from Beijing. This is the third webinar of our Chinese Neurosurgical Journal, a special channel of Neurosurgical TV. And tonight we will have three speakers. And please allow me to introduce the first speaker, John Adler. As I guess most of the neurosurgeons all around the world know him, and he's the professor of neurosurgery from Stanford University. And as we know, he's the father of Cyberknife. Tonight, he will give us a special speech, talk about a new website named cureus.com, a new age for medical publishing. So please, Professor.
Yes, Professor Adler. I come from Huashan Hospital. You know Huashan Hospital. We have the two Cyberknives.
Oh,
One is the latest model. Thank you for the Cyberknife.
Yeah, yeah. Professor Xu is he's the co-hoster of this special channel. Yeah.
Well, I love Huashan Hospital. Well, I have many Chinese friends, but I'm going to show you at my final slide something even newer than the Cyberknife, son of Cyberknife.
Okay, great.
So just one slide, but most I want to talk about a website that I've worked on for more than 10 years, and it is a different way to publish medical knowledge. It's called Curious. That word in English means kind of two things at the same time. One is it's a play on the word curious, to be thinking imaginatively and in new ways. The other is cure us. How do you cure diseases together? And so it's a different way of medical publishing. And in the end, a little like the Chinese Journal of Neurosurgery, it's about eliminating barriers to the generation, curation, and the dissemination of medical knowledge. So, you know, the world of medical publishing is a big world. And there are, as you know, lots of different ways to go about publishing. But it's also pretty clear that this publishing is very, very important in the world of healthcare. Over the last year during COVID, we've seen how decisions made by governments affecting billions of people have all been reported and first described through medical journals. So medical journals are critically important in the world. And of course, as neurosurgeons, we know how important it is to our own specialty. The future is decided by what's published in journals. However, journals also have not changed very much over literally hundreds of years. Journals started with things like, you know, Nature and Lancet, New England Journal of Medicine, and they're hundreds of years old, these medical journals. But increasingly, they've become harder to access. They become very expensive. Even wealthy universities like Harvard and Stanford find it hard to pay for subscriptions to these journals. And in fact, the vast majority of physicians in the world, the vast majority of neurosurgeons in the world often don't have access to the critical knowledge in medical journals. Meanwhile, many journals have become obsessed with impact factor. And in fact, many of the observations, some of the most important observations in medical history, would never be published in modern journals because they lack the significance that medical journals are looking for today. Things like the discovery of penicillin, things like the description of anesthesia in Mass General in New England Journal of Medicine would never be published today. And so unfortunately, journals have held back medical progress. And I want to point out a special shout out to Ms. Tu, who won the Nobel Prize, really developed on the work of ancient observations around the use of, was it red rice rust and the ability to regulate human cholesterol. That kind of observational science by over thousands of years of traditional Chinese practitioners would never get published in today's journals. And yet it was eventually important enough that it led to her Nobel Prize. So because of the problems in some traditional medical journals and growing up here in Silicon Valley, I have spent the last decade thinking about a new generation kind of medical journal, medical knowledge platform. Curious is a little bit different than other journals because we believe that all medical knowledge, if done written credibly, deserves to be published. We don't believe in rationing healthcare or medical knowledge. We want to open it up to as wide a community of publishers as possible. So much publishing today is just done among the best universities of the world. But 99% of the physicians who oftentimes make important observations like I just described, like penicillin, like anesthesia, we want them to have access to journals as well. And so this new journal is very much a new generation concept, free for all, but also very tightly integrated with social media. In fact, we think journals were the very first types of social networks, and we're taking advantage of that to have a new business model and to dramatically lower the cost of publishing. So in Curious, we have gone out of our way to integrate tightly with social media. In fact, a medical article is merely user-generated content around which we build a social interaction. By doing that, we are very much like the modern internet. We are thereby able to make publishing highly affordable. We publish 1/3 of all articles for no cost, and 2/3 we charge only $300, which is the lowest cost in the industry. And we enable very fast publication times. The average time from submission to publication is only 2 weeks. I think of it a lot like posting on a form of social media. Of course, you have different social media in China than we do in America, but you know how instantaneous it is. The difference is that social media in Curious is always peer reviewed, and it formats, and it's done in a way that closely follows the traditions of both peer review and medical publications. And once published, this content is available to the world. And increasingly, we find patients want to read this content, not just physicians. So we have some authors who can publish even in days. The way Curious works is it's a user-generated HTML page. So the author does a lot of the work, not the journal, the author. And that's how we can keep costs so low and make the process so fast. And once authors become familiar with this, they can oftentimes publish their article in just a few days, because peer review also happens very quickly. We call it template-driven publication. So the peer review process is somewhat familiar to anyone who publishes in journals today. In Curious, it is a single blind peer review. And we're currently publishing about half of all articles that are submitted. Some articles we would like to publish, but they're just not good enough quality. And if the authors will spend more time and effort, we will often publish articles, but we find that once again, 50% of articles just aren't good enough. Of note, over 60% of articles are published in only 2 weeks. It's a very vast publication cycle. Once published, we subject all articles to what we call SIQ. It's Scholarly Impact Quotient. It is a way of measuring the intellectual importance of an article. All readers are invited to score the impact of the quality of the published article. And what we find is that collectively, when many people score the importance of the article, you get a new measure of importance that is in some ways better than impact factor. We hope to get our impact factor next year, but we think that SIQ closely complements impact factor and in the long run may be more important because it reflects not the quality of the journal, it reflects the quality of an article. And ultimately is the quality of the articles that decide the importance of a journal and the impact factor. Like the Journal of Neurosurgery, Chinese Journal of Neurosurgery, we believe in open access. So 100% open access. And of course, as you know, much of the world is moving towards open access. Although only 25% of articles are open access today, it is growing quickly. And my understanding is even in China, there's a big move afoot to support this Plan S, which comes out of Europe. Someday, it is likely in the next 2 decades, almost all articles will be open access. But to publish open access in Nature cost $11,000. That's a lot of money for anybody, even in Western countries, wealthy countries. So Curious is able to keep its publication process so low cost because we use the author to help do a lot of the work that traditional journals often do. So we use different types of tools and internet technologies. You would not know about TurboTax, but that's in America. That's how that's how taxpayers submit their tax return through software, sophisticated software. We have, like not Uber, in China you had Didi, where one moment you can get a driver if you need it. In our world, we have copy editors who jump on and jump off, or from low-cost countries like the Philippines, Ireland, and in India. And then lastly, we have this community engagement, which I described SIQ, which is like what we see in WeChat when people interact in and around user-generated content. The community interacts, also something that we have in Facebook in America. So you may not know about Curious, but Curious is growing very quickly. We published 8,400 articles last year, and we continue to grow at a rate of 60, 70% a year over year after year. And so we had over 16 million page views last year. This year, we're expecting close to 40 million page views this year, as the journal continues to grow just time after time after time. With 40 million page views, we will be one of the busiest journals in the world. So last year, we had 16,000 articles submitted. I'll add that in total, we published 1,000 neurosurgery articles. But all these numbers continue to grow year after year. Once again, 16,000 articles submitted, over 8,400 articles published, about 50%. So when we add in PubMed page views, our articles were read, Curious articles were read 30 million times last year. This year, we expect to be over 50 million between Curious and PubMed reads. 50 million is a pretty big number, and we're quite confident that we will be even much bigger in the years to come. So Curious currently has 12,000 worldwide registered neurosurgical users and authors. And we have in fact, we have over 300,000 registered members. Now, I suspect, I don't know how many neurosurgeons you have in China, but you may well have 10,000 neurosurgeons in China. And we'd love to, of course, have even more neurosurgeons participate in our journal. And it's a great way to get your articles read quite widely. Last year, we had a few articles that were read between 500,000 and 1 million times. An individual article was read 500,000 times. So as you can see, Curious continues to grow quickly. The United States represents about half of our authorship, about half of our users and reviewers, but we certainly have representation throughout the world quite widely. China, however, is very underrepresented, and we would urge you to consider our journal, especially if it's non-neurosurgery material, or you want a broader audience, especially if you want an audience outside the United States. Please consider Curious. You'll note that half of our articles are by young people, 34 and yes. But our most published author is Shane Tubbs, the editor-in-chief of Gray's Anatomy, who's published close to 200 articles over the last several years. So while we're still a small journal, given all the number of articles in the world, we think we can be publishing close to 10% of all medical articles in the next 4 years. In fact, in the next 3 years, we're quite confident that Curious will be the largest medical journal in the world, reaching an audience of more than 100 million. So it's an audience that includes physicians, there are surgeons, of course, but increasingly numbers of patients, because patients want to know what state-of-the-art medicine is. And we look at that as a human right. So please come check out Curious. Obviously, it's free to sign up and read, and would welcome appropriate publications in Curious as well, if it doesn't fit inside the Chinese Journal of Neurosurgery. And so I already showed this. So please, if you want to learn more, just reach out me through Curious or at Stanford. I'm pretty accessible in the world today. And lastly, I just want to show you not only that this, while as proud of it as I am of the Cyberknife, I want to show you the son of Cyberknife, the first such brain and head and neck radiosurgery machine, which is really a combination of a gamma knife and a Cyberknife and something different. And it does not require radiotherapy vault. So it goes very easily in a neuroscience center. It goes easily in a neurosurgery clinic right next to your patients. And this machine is designed to deliver the best radiosurgery in the world and also do it for much less cost than was ever possible before. And so this is the ZapX, and I like to call it the son of the Cyberknife. And while we have one installed at PLA 301, I hope that we'll have many more installed over the next few years in China. Once China opens up, I intend to visit all my many friends there. So thank you, Yuan Li. Thank you, Binju. You know, it's nice to be able to present to what I'm doing at Curious. And also just remind you, I'll be there soon to talk about the ZapX. Thank you.
Thank you, Professor Adler. I have seen this machine 3 years ago in Naples. I still remember. It's a very, very impressive.
Yeah,
Well,
I heard there is a similar one. I mean, maybe it's only for clinical trial in the China, the PRA General Hospital. I'm not sure if this exactly the same one. Or,
yes, it is the same machine. We ran a clinical trial there, and we have we have a pending decision from the NMPA to get final regulatory clearance. We in fact have to do one last test, a electrical test, to make sure that the electrical systems are safe. But that's been a little difficult because Beijing is locked down, or has been more or less locked down for the last several months. But once we do that test, we will have regulatory clearance in China. And so we've sold 40 machines in the world, but I promise you we'll be selling many more, and look forward to visiting you and telling you more about it.
Thank you. Yeah, it's amazing. Huh? So basically, it's for radiotherapy, but it can be used for not only neurosurgery, right?
It's only for the brain and head and neck. So it's for neurosurgeons, ENT doctors, and radiation oncologists treat brain and head and neck tumors. And it's
Okay.
also we're also treating, and I'm hoping to someday at Washan Hospital, put a machine there and treat neuromodulation. The idea of down-regulating brain circuits for
Oh.
depression and addiction. So we have many ambitions. I have big ambitions for China, and I can't wait to visit. You know,
Yeah.
You're
it's been
welcome.
painful. For two and a half years, I've not been back to China.
Yeah.
And then in 2019, I was there 10 times. So I can't wait to see China again.
Okay.
So
And-
Enming Wang is a good friend of you. Wang Enming
Oh, yeah.
of Huashan Hospital. He is in charge of the, he's the chief for the Cyberknife.
I know well, yes, and I need
Yeah.
to visit him. You can tell, if you see him, tell him I can't wait to see him.
Okay.
I
Thank
want to
you.
drink some Mao Tai together. We want to drink some Mao Tai.
Okay, you like multi, okay,
With good friends, yes.
okay.
Right. Oh, another question is about the curious. So I know this is like a new internet journal, or right? And you are the chief editor. So how many articles published? I mean, the submission come from China. As you said, there are more than 10,000 publications already.
Well, very few. That's why I'm on this call. Because
So-
I would like to publish many more. So China, as you can see, is only 1% of our submissions. You know,
Yeah,
but
we can try.
get
Yeah.
many more articles from you know, Japan, and many more are from the Britain and the UK and Germany. I mean, China is very underserved. That's why I would like to, you know, let you know of what we're doing. So here, this is the slide. So you can see in there that
Yeah,
if you see in this slide, you'll see China is very small, only 1%,
okay.
only 1%. So I want to change that.
Maybe that because I mean, still China is still, most of us still not familiar with this new journal. It's like a journal for general medicine, right? Or specialty in medical area, right?
Yes, all specialties. We represent 61 specialties. But we published 1,000 neurosurgery articles last year. So still a lot of neurosurgery. And and everything is, we double in size every 2 years.
John, it started as a neurosurgery journal, right? But 100%?
Started 100% as a neurosurgery journal. It started in the Department of Neurosurgery at Stanford. That's where I started the journal.
I think the SIQ is a very creative idea to make the reader to make the score of the article.
Maybe that's something our journals could share together.
Yeah,
I'd like
Yeah,
it to make it a new. Yeah.
Yeah, we are still a small journal, you know, Chinese neurosurgical journal. We got around 200 submissions every year, and only publish about 40 articles in last last 3-4 years. So yeah, we are still growing.
Yeah.
So
Yon Lee,
yeah.
who is your publisher? Who is your publisher?
Oh, we cooperate with the, you know, the Biomed Central. It's a BMC.
Well, if you want a new publisher, I'd be happy to be your publisher, and I'll publish for a lot less money.
Okay.
Okay? Because we
Oh,
do that.
Sounds like a
Thank you.
winner.
So we work with a number of medical societies too. So a
Mhm.
number of state medical societies, the Radiosurgical Society. So there are other organizations, number of medical schools. So we publish journals for in a number of different situations, and we do it for very low cost. You can
Yeah,
communicate
maybe-
with me, and you can tell me how much you spend, and I'll tell you it's too much.
Okay.
I can do much
Okay.
better.
I'm
Maybe
not
you
sure.
can cooperate with the Asia Journal of Neurosurgery,
Yeah,
ACNS, ACJNJ, yeah,
I would love to.
Asia Journal of Neurosurgery, yeah.
yeah.
So you should check out Curious. We'll see, we have what's called a channel.
Mhm.
And a channel is like a journal. It's a small journal. It's a part of Curious that's dedicated to a specific medical society, to a specific medical specialty. And we could easily make a Chinese journal of neurosurgery. And it will be very low cost, super low cost.
So Professor Adler, would you please share the last one with your website?
Yes, sure. I'm sorry.
Oh, and I saw a question from
Yeah, okay.
Hashang. He asked, do you accept case report or only research article?
We accept case reports, absolutely, yes. In fact, remember, the report of anesthesia was a case report. So when the most important article ever published in the New England Journal of Medicine was the description of anesthesia, and it was a case report. So we believe that case reports can be extremely valuable, and yes, about 30% of what we publish is case reports.
Okay. Thank you. Thank you again. Okay. So yeah. Now,
Appreciate.
thank you again. Yeah. Hope you can visit China as early as possible.
Tell
Yeah.
President Xi to let me in. I want to visit.
Okay.
Okay.
But I can't do
Thank
3
you.
weeks. No 3 weeks of quarantine. That's too much. Too much.
Yeah, yeah.
Okay. Yeah. So, okay, now let's
Thank
move
you. Thank
to
you very
the-
much.
yeah,
Thank you.
move to the second speaker, Professor Yin Yan Wang. It's from Tiantan Hospital, Capital Medical University, and today he will talk about a radiomics-based biomarker prediction model for glioma and its application in surgery. Dr. Wang, please.
Yeah, I'm here. Good evening, professors and audience. I'm very honored to be invited by Professor Zhao and Chinese Neurosurgical Journal to share our work. And today, I'd like to share our work titled by radiomics-based biomarker prediction model for gliomas and its application in neurosurgery. So first, introduce a little bit of myself. I'm Wang Yinyan, a neurosurgeon from Tiantan Hospital, and I worked in the team of Professor Jiang Tao. And recently, we published a paper named "Role of Molecular Biomarkers in Glioma Resection." It's a systematic review published on Chinese Neurosurgical Journal, and we think it's a creative topic because recently we found that when we know biomarkers before the surgery, it may guide our surgery in the future. So we investigate on this topic for many years and try to investigate it more. And our teams consist of two parts. One is clinical neuroimage parts, and the second one is genetic analysis parts. So I'm from the radiogenomic parts, and which are consist of two groups, and then we call it radiogenomic group. So we are working on this glioma treatment pipeline. So now we first have MRI, and then we perform surgery, and then we got pathology of glioma, and then we know and give a best treatment for the patient with adjuvant therapy. So under this pipeline, we have performed many surgery, but now we have a question that whether we can predict pathology before the surgery and whether the results that our prediction can guide the surgery. So with this question, we review many papers and we would like to perform our investigation, and maybe in future it can change the pipeline of glioma treatment. So we would like to solve the problem, but first we have to make a steps. The first step, we would like to know the anatomical relation of biomarkers in glioma. The second step, we would like to know the morphological relation of biomarkers on MRI. And the third step, we want to know the radiomic correlation of biomarkers. And then with all this knowledge, we would like to establish a radiomics-based AI prediction model for gliomas. So maybe we can know more biomarker information before the surgery. So in the first step, we try to establish a voxel level mapping of tumor-related biomarkers. It started 2014 and duration is 3 years. And we published 9 papers on how the voxel level mapping of tumor-related biomarkers are. So our idea from a New England paper that gliomas may originate from SVZ. SVZ is a specific area in the brain, and with many evidences, we have a hypothesis that when glioma start from the SVZ, it moves to other area of the brain and cause many gliomas in different brain lobes. And what we want to do is to perform and generate an atlas. This atlas shows that when a glioma originates from one brain area, how many percent it can be Adler mutated or other biomarkers expression. So we choose 10 biomarkers from our published guidelines, the CGCG guidelines, which is used in China. And then we perform normalization. We input MRI images and normalize them into MRI standard space. And then we separate them into high expression and low expression of specific biomarkers. So in this regression, we can know in each voxel that how many percent of the tumor are expression of one biomarkers, high expression of one biomarkers. That in other areas, it may be low expression of biomarkers. So with this fitting model, we can know in where the glioma originated, that it may be start with IDH mutation or 1p92 codylation. So our one paper published on AGNR, that was first a paper of the series publications that we found in temporal lobe that P53 mutation is much more higher than glioma originate from other brain lobe. So this paper are highlighted by the editor of AGNR, and the next year he got the Lucian Levy Best Research Article Award nominated. And then we try to use this method to see the association between biomarkers and brain regions. This is our another paper that shows the P10 mutation and EGFR exploitation, which area of those biomarkers are highly occurrence. So here is our funds that this series article shows the specific area of the brain are associated with a specific biomarker mutation. So that was the first step of our investigations. And our second one is radiogenomic correlation of tumor-related biomarkers, which is started at 2015. So the duration of this is also the 3 years, and we published 8 papers on that topic. So for example, we would like to see how the MR features are associated with VEGF expression. We can see on this slide that there is necrosis area, tumor contrast enhancement, and the T2 abnormal signal areas. So we calculated the ratio of necrosis areas to enhancement areas. And we found this ratio are highly associated with VEGF expression. And on SWI, the specific MR image, and we can see there is a score ITSS, which is also highly associated with biomarkers like IDH, MGMT, and 1P19Q. So we can see that with multiple sequence of MRI, we can know many evidence that how glioma biomarkers expression. So these are publications on this topic. And then we move to the next step, that how MRI assist predicts molecular biomarkers. So firstly, we abstract radiomic features from MRI, which is more than 1,000. And then we use these features to establish an AI model. And use this AI model, we can know that how biomarker expressions before the surgery. So take example that this is our one investigation that we would like to know the radiogenomics features of PTEN mutation in glioblastoma. So we first draw the tumors on CE and on T2, and then it was checked by radiologist. And we use TCGA data to be training data and CGGA data to be validation data. And then we can have a feature selection model, and we construct a model with SVM. And by MRMR, we establish a prediction model, which was a highly prediction effective. And then we establish an AI prediction model for PTEN mutation, which can classify whether this tumor has PTEN mutation before the surgery. And we also found it's associated with cell motion and signal cascade. Then we use the same method on P53 and establish a model to predict P53 status in LGGs. And then we also published a paper use DCNN to predict IDH1s. So here are all the biomarkers that we can predict now. And use these models, we can predict more than 10 biomarkers before the surgery. So now we move to the treatment pipeline of glioma. So based on our investigation, it's possible that we can use the preoperative MRI features to predict pathology of the tumor and how this knowledge can change the surgery. So we perform another investigation. The first one is we combine with the Huashan Hospital and published a paper on 2018 that we can know that 1P19Q status are highly infected, whether the patient can get any benefit from total resection. And we found that when patients have 1P19Q co-deletion, it may not benefit from total resection, but have more chance to a functional dysfunction of the patient. And then there is another paper published on JAMA College, which shows that when the patient has IDH mutation, whether we choose graft resection in glioblastomas. So it found in a specific group of patients, cross-total resection is benefit to the patient, but in another group of the patient, cross-total resection is not benefit. So especially for IDH wild type group. So we reviewed this article and published on Chinese Neurosurgery Journal that whether we should choose a super resection, or we should choose a total resection, subtotal resection, or we only have to resect enhancing area. But the evidence level of those articles are not so high. There is no RCT investigation. And then we perform the investigation with our database, CGGA database. So we collect all low-grade gliomas and IDH mutated and IDH wild-type gliomas, which is now the high-grade. And then we want to see whether total resection are benefit to the patient with specific classification of the biomarkers. We found that when we only see the pathology type and all of the total resection are benefit. So we would like to see in specific group whether this total resection still work. So we further separated patients into specific groups, like the group with KPS less than 80 and age larger than 45 years old. And we found that for the patient with KPS less than 80, there generally gross total resection is not that benefit. But for the patient with a good KPS and a young patient, generally gross total resection is works. And specifically on this figure, we can see that this is our result based on our CGGA database, which consists of more than 3,000 patients' data. So we published this paper on Cancer Letter and would like to push this topic a little bit forward. So this is our result, and this is all I want to share with our audience and host today. And thank you for our team and all the work are performed by our team that we published more than 60 papers for recent 5 years, and there is 4 with impact factor higher than 10 papers. Thank you very much.
Thank you, Dr. Wang. And that's interesting. Last week, for 2 weeks ago, we also have another Professor Guo from Harbin Medical University. He also talked about the glioma stem cell, the basic research. So, Dr. Wang, can you give us a little bit more explanation about what about your opinion for the glioma stem cell? Can we actually use some special technique to identify them? I mean, also for the, I mean, like for its application to the surgery. Yeah.
Okay, thank you, Professor Zhao. It's a very good question, and it's very hard to answer right now because tumor stem cell is a long story, and we think there exists the tumor stem cell, and with those tumor stem cell, the glioma are originated and develop into different types of glioma. So the idea is that when we can kill the stem cell of the glioma, then maybe we can kill all gliomas. But we found it's harder than what we thought because there may be multiple types of glioma stem cell and maybe more than one glioma cell in the tumor, in one tumor. So it's difficult to see or to make those tumor stem cell appearance in the tumor. So it's difficult to know whether or say where those tumor stem cells are. So then I think when we can kill those all tumor stem cells, it's maybe we can kill all the tumor cells. But the first question is how that we can localize those tumor stem cells. So if we have a technology to deal with this problem, maybe you can success. Okay, thank you for your question.
Okay, and we had a question from the panel. is this prediction confirmed by histopathology to correct? Yeah, I guess
Okay.
he asked about
Yeah,
your prediction confirmed by the pathology. Oh.
okay. So I should firstly say all those prediction model are generated from the pathology because we have MRI features and we have a pathology, and we use those MRI features to predict the pathology. When we're trying to do this, all markers are based on pathology. So all our models actually are based on the pathology results. And then we validated our models by the database from other hospital. And we think when more than one hospital can repeat this result, it's maybe more validated. Okay.
Thank you. So do we have any more questions? Okay, so thank you again, Professor Wang.
Thank you.
Okay, so Dr. Yeah.
Okay,
Professor
thank you, Dr. Wang, for your very nice presentation. And it's, I think it represents the maybe future of the for this kind of glioma treatment. It's a very important site for this future treatment of gliomas. So now the third speaker is Dr. Shifong. He is an associate professor of Quotient Hospital of Neurosurgical Department, and my younger colleague. He is a very talented hybrid neurosurgeon, and he can both do the very good open surgery for clipping aneurysm and also the interventional treatments, even the bypass. He can also doing very well independently. My another younger colleague, Dr. Liao Yujun, he also did a lot of translation work for this neurosurgical TV. John is very familiar with him. So now, please, Shifong.
Okay, can you hear me?
Yes.
Yes.
Yes. Good evening, everybody. Thank you for the invitation of Professor Xu Bin and Zhao Yuanli. And thank you, everyone. So, as my leader introduced, we performed both the open surgery and the endovascular procedures. So today my topic is surgical clipping of the pericleanoid aneurysms in the stent flow diverter area. The pericleanoid aneurysm is defined as an aneurysm arising from the segment of the ICA between the distal ring and the origin of the PCOM. So it's also called ophthalmic cell segment aneurysm, or sometimes the proximal ICA aneurysm, ventral ICA aneurysm, and the carotid cave aneurysm. And according to the classification of the segment of the ICA, the C6 ophthalmic segment is called as pericleanoid aneurysm. This is an anterior posterior view. And this is a lateral view of the segment of the ICA. And we can see the C6 segment is called ophthalmic artery segment of the ICA. And in our group, the treatment category was described as follows. And most of the pericleanoid aneurysm were treated by the endovascular procedures. For small and medium-sized aneurysm, we first choose the stent assist coiling, including the laser cut stent or braided stent. For large or giant pericleanoid aneurysm, we usually perform the fluid diverter. But in some cases, some indications, surgical clipping is preferred, and the bypass is the last choice. As shown in the figures, for small and medium sized C6 aneurysm, the Enterprise and the Neuroform Atlas is open cell stent. Also can achieve the good results. And the braided stents such as Elvis and Leo can also achieve the good results. And for the large or giant aneurysm, the pipeline and the fluid diverter is first choice. And the pipeline is also everybody knows. And the made in China two bridge. And the figure shows the tandem intracranial, the pericleanoid aneurysm, and the pipeline was used. And this is also two tandem aneurysm, the two bridge was used. And sometimes the coils, stent assisted coiling was used for large or giant pericleanoid aneurysm, especially for aneurysm with the jet signs. And however, in some situations, such as the multiple intracranial aneurysm and peptic ulcer and antiplatelet allergic or large sac narrow neck and intraflow jet and economic factors and surgical clipping was used. And the most used the classification is a Barami classification in 1994. And the type 1A is the aneurysm arising from the superior ophthalmic segment of the ICA and related to the ophthalmic artery. So it's also called ophthalmic artery aneurysm. They were either medial or lateral to the optic nerve. And the type 1B is had no branch relationship. The projected superior and were lateral to the optic nerve. And the type 2 is aneurysm arising from the ventral segment, ophthalmic segment of the ICA. And the type 3A is the aneurysm projected medially over the dorsum sella. So it's arising from the medial segment of the ophthalmic segment of the ICA. And the related, so it's called the superior hypophyseal artery aneurysm. But type 3B is arising from the C5 segment, also called the clinoid segment of the ICA. The projected medially infradiaphragmatic. The type 4 is, or we can call it belongs to the C5 or C4 is cavenous sinus segment. So I will show some illustrative cases. And this patient was a 44-year-old female and suffered vision decrease in the left eye. And we can see from the DSC, and we can the jet sign is the narrow neck with the inflow jet. So we are worried about the post-operative hemorrhage after the flow diverter. So the surgical clipping was chosen, and we use the superior orbital lateral approach. This is an aneurysm, the IC and ICG, and we can see the video. And the severe dye fissure was dissected from the distal to the proximal fashion. And the optical system and the cortical system was open to expose the ICA and aneurysm. And we can see here the aneurysm. And the anterior, the dural covered anterior clinoid process was incised. And a high-speed diamond drill was used to remove the medial aspect of the anterior clinoid and the lateral of the optic canal. And we use sharp dissection to remove some part of the anterior clinoid process. Sometimes it's adhered to the dura. The gel foam is used to perform the hemostasis. And the falciform ligament and the distal ring of the distal ring was opened to expose the proximal neck of the aneurysm. And the Peckham artery, the A1 was temporarily occluded. And we are exposing the distal neck of the aneurysm and the proximal neck of the aneurysm. So a straight clip was used to be parallel to the ICA to reconstruct the ICA. And the temporal clips were removed, and the ICG confirmed the total obliteration of the aneurysm. And then we puncture the aneurysm and dissect the aneurysm dome from the A1 and optic nerve, chiasmatic. Now, another clip was used to reinforce and we incise the aneurysm body. Okay, and this is another case. A 56-year-old female complained of intermittent headache. The patient was admitted in 2017. At that time, the fluid diverter is not available, so we performed the operation in the high breathing room, and it's a giant ophthalmic artery aneurysm. This is after the removal of the anterior clinoid process, the proximal and distal aneurysm was exposed, and multiple clips was used to reconstruct the ICA. And this is the intraoperative DSA in the hybrid room. And we also use the balloon guiding catheter and use retrograde suction to decrease the intracranial aneurysm pressure to facilitate the clipping. And this is a 5 years follow-up. We can see no recurrence. It's also another large pericleanoid aneurysm because of the economic factor. 2 clips, straight clips was used to clip the aneurysm. This was done in foreign province. And that 1B, and we said it has no relationship with the ophthalmic segment, but it's the aneurysm projected laterally. And this is after the operation, the ICG, and we can see the video, show some video. And the key point of this type of aneurysm is to remove the lateral and the posterior aspect of the anterior clinoid process. As a high speed, the diamond drill was used. And this is optic nerve canal. The roof has been unroofed. The anterior clinoid process was here. It's removed. And another key point is to expose the proximal neck of the proximal neck. We should dissect the plane between the aneurysm dome and the cavernous sinus roof. And here is to expose the proximal neck, and the A1, the M1 was temporarily occluded. And we use Dallas, the ICA retrograde suction to facilitate the clipping. And first, the pilot clipping used a long straight clip was used to clip the aneurysm neck. And we here. Another straight clip was used to reinforce the clipping. So the temporary clips were removed. And we can see here is the dog ear, the residual neck. To expose the perforator. The ICG should know fitting of the intra-aneurysm that contrasts the angles. Another straight clips was also used to totally or clip the aneurysm neck. So it's another case, aspirin allergy. So also type 1B, and we can see here the aneurysm, and this is the aneurysm after the removal of the anterior clinoid process, and expose the proximal neck and perpendicular fenestrate, and another perpendicular was used, and this is the postoperative CTA, totally obliteration. Also another case, 1B, because of the peptic ulcer 52 years old male, and then 2 perpendicular was used to reconstruct the ICA, parallel to the ICA. And it's also a ruptured and ophthalmic artery type 1B. A perpendicular clips were used. This is another ruptured when I was in Xinjiang province, and pipeline was not available. It's ruptured type 1B. It's a giant aneurysm. We also use 2 clips, straight clips to were used to be parallel to the ICA, and the totally clipped the aneurysm. And the type 3 is located at the ventral surface of the ICA. We can see there is a multiple intracranial aneurysm, is MCA, tiny aneurysm, and a PICOM aneurysm, and it's also type 2, the pericleanoid aneurysm. So it's a curved clips was used first to clip the MCA bifurcation aneurysm, and a straight clip was used to admit the PICOM aneurysm, and oblique fenestrate clips was used to clip the pericleanoid aneurysm. This is a post-operative angiography showing total obliteration of all these 3 aneurysms. And this is another case of the recurrent aneurysm after coil embolization. Type 2, we also used a perpendicular fenestrate clip to clip the aneurysm. And the type 3A, as we introduced, is also called the superior hypophyseal artery aneurysm. Is projecting the medially, and we can see here, medially, inferiorly. And this is a large pericleanoid aneurysm, and complaining of 49-year-old female complaining of the intermittent headache because of economic factors, worried about the pipeline, the high cost. And so we performed the operation in the hybrid room, and this is a post-operative, and we can see the video. And we also dissected the CV fissure from the distal to proximal fashion. And we open the optical system and the carotid system to expose the optical nerve and the ICA. This is aneurysm. Now we inside the dural cover the anterior clinoid process. And the key point of this type of aneurysm is that to remove the lateral aspect of the optic canal, and the extent of the removal of the anterior clinoid process is not too much, just a minimal aspect of the. Sometimes you don't need to remove the anterior clinoid process. And this is a falciform ligament was opened, and the distal ring was also open. And we elevating the optic nerve to expose the proximal neck and the posterior. A pilot clipping, I think the first fenestrate clip was mostly important because they're always used to reconstruct the ICA. If there is stenosis of the ICA, you should adjust the clip. And the second was used in parallel and in condemned fashion. And this is the third, to avoid occlusion of the perforators anterior coil artery or the perforator from the ICA. And this is after operation and the ICG. And this is another case before the general anesthesia, the patient falling unconscious and from the unruptured to ruptured. We perform the emergency aneurysm clipping and also expose the aneurysm, use 3 perpendicular fenestrate clips to reconstruct the aneurysm. We also perform the operation in the hybrid. This is postoperative angiography. It's also another case in Huashan Hospital conference. And this is a multiple intracranial aneurysm, the giant, the type 3-1A, but also have the A3 segment and the anterior clinoid artery aneurysm. Flow diverter was not used because of the tortures of the ICA. And we use the 1 fenestrate perpendicular and 2 curved to reconstruct the ICA. And this post-operative angiograph showed the total obliteration of the aneurysm and the parietal artery patency. And the type 3, I think, is most difficult because you need to expose the C5, open the proximal ring. And the patient was a 49-year-old, complained of headache, irregular shaped daughters, and also a perpendicular fenestra was used. This is the post-operative. And a contralateral approach is also can be performed to expose. For this patient is the right side MCA bifurcation aneurysm. We can see here. And we use this lateral superior approach here, aneurysm. And a straight clip was used. This is the ICG. And we also find the contralateral, the C6 aneurysm here. And then we expose the inter-optic fissure and expose the aneurysm and a straight, also maybe sometime to clip the aneurysm. This is a post-operative CT shows the aneurysm was totally cured. And the key points of the surgery of the clipping of the pericleanoid aneurysm is the individualized anterior clinoidectomy. The extent of the clinoidectomy, I think the type 4 is the most, is larger than type 3B and 1A, 1B, and then the last, the type 2 or type 3A. And the second key point is wide opening the distal ring and exposing the proximal neck. For large or giant aneurysm, retrograde suction dust technique or balloon assisted may be useful. So I showed some the figures of the remove of the anterior clinoid process. So there are 2 approaches. One is intradural, the end block removal. So you can see here from the optic nerve, maybe 10 millimeter and transverse to the spherically fissure, optic fissure, and this is anatomy. You can see here an end block. This is a clinoid segment of the ICA, and this is optic nerve. And sometimes we can use extradural anterior clinoidectomy. So maybe the posterior approach was used epidural. The posterior part of the upper roof was removed and this here because of time limited. The high. this is a temporal lobe. This frontal lobe, a high-speed drill was used. Here we can see the superior orbital fissure. And last, the anterior process was removed. So there are so many publications in the internet literature review, and the techniques such as the suction decompression and retrograde suction, trapping evacuation, and retrograde suction decompression use balloon occlusion or temporary office the balloon occlusion at the neck of the aneurysm. And also the retrosuction decompression use a balloon containing guiding catheter. So conclusions, the clipping strategy for pericleanoid aneurysm depends on the classification and the aneurysm size. The clip application is used parallel to the ICA in type 1, whereas the fenestra clips are used frequently in type 2 and type 3. The balloon-assisted retrograde suction decompression facilitates the clipping of the large and the jointed pericleanoid aneurysm. So now in China, in our group, maybe 95% or more than 95% was prefers endovascular surgery. Clipping became more or less. So that's all. Thank you. This is our paper. Thank you.
Okay, thank you, Professor Shifong. And any questions? So we learned a lot from Professor Yuhan, and his name is LSO approach. So normally you can see Dr. Shifong introduced mostly adopted the approach is a lateral supraorbital approach. And quite often we will do the intradural removal of the anterior clinoid process. And this makes this procedure much shorter. And if you use richer suction balloon guiding wire, guiding catheter, it makes the dome of the aneurysm relax and shrink very well. So it's very helpful. We don't use adenosine to stop the heart beating.
Ben, there's a question from Mohammed in the chat. Do you want to read that, please? Mohammed Helmi.
Oh, that.
Yeah, Mohammed, you can speak directly.
Are you there, Mohammed?
Yes, hello everyone. Thank you for giving me this chance. I'm Mohammed Helmi from Egypt, the master degree student of Professor Binshu. My question is, it was published that coiling increases the size of aneurysmal sac. So in case of aneurysms that compress the optic nerve, I wonder if coiling would increase the mechanical compression in optic nerve. So that in return will cause more visual deterioration. I asked Professor Shu if he have noticed any cases like that. Thank you.
Thank you for raising such a good question. For the giant aneurysm, the compression of the optic nerve is a major problem. So for this aneurysm, we usually use the pipeline, but maybe 4 coils or 3 coils, just partial coiling. So we are waiting for the reconstruction of the fluid diverter. And then maybe you in the follow-up angiography, you will or MR image scan, you will found the shrink of the aneurysm body. So I think the optic nerve, the compression of the optic nerve is not a problem.
Okay, thank you, Professor Fenshu, for your answer, and thank you for your valuable presentation.
Dr.
Yes,
Shi,
for
I have a
for
question.
the giant aneurysm, normally we prefer
Oh.
the direct clipping because it's more economical.
So Dr. Xu, also to Dr. Xu, yeah. Okay, so I have a question about the Dolan's approach. I saw your video, the last part you introduced about the Dolan's approach. So I wonder if what is the indication for you to choose this extradural approach, or for some special kind of aneurysm, or you just do it with like a personal favorite?
Yeah, thank you, Professor Zhao. Maybe 3 years before, I was in the Little Rock City. I asked the Professor Ali Christ, because ophthalmic artery aneurysm, the type 1, is dangerous, is projecting the superiorly. So when we use the Dolan approach, maybe elevating the frontal lobe, I asked him about the hemorrhage during the operation. He said it's not a question, never. But for me, I like to use epidural, the Dolan approach for the type 2 or type 3. The aneurysm projecting the medially and ventral and medially and inferiorly of the ICA. And for the type 1, the ophthalmic artery aneurysm, I would like use the intradural remove of the ACP. Okay.
Okay.
Yes, that's a reasonable choice. If you want to expose the more proximal part of the ICA, you may choose the Dolan approach. And if you don't have the balloon catheter, you can use the Dolan approach to get the proximal control of the ICA.
Yeah, Dolan approach is always used to expose the cavernous sinus of the ICA.
Yes.
No need to expose the cervical ICA.
Yes, that's a one-stage treatment, and unnecessary to, if you don't have the hybrid room, maybe this is a better choice.
There's one question from Abraham. Do you see the question there, Ben? From Abraham. Do you want to ask that question directly, Abraham?
Yeah, please open your camera and say it
Are you there, Abraham?
Yes, I'm here.
Oh, good.
Thank you.
Mm-hmm.
Thank you so much. Thank you for the good topic and good presentation by Professor Shifong. One of my questions have already answered. My other question is about the complication in this kind of type of aneurysm. What is the most complication have you been in your experience?
I refer in the earlier operations in my the operation for the pericleanoid aneurysm. I remember the just the one case as in my video, in my PPT, the type 3B. Maybe
Okay.
it's the second case. I used the no QSA, just the high-speed drill, and I used the en bloc technique to the wider extent remove of the ACP. So the patient suffered the visual some extent, some part of the visual loss. Okay, decrease the vision after the operation. So the completion, I think it's okay. In Alquist, he said the pericleanoid aneurysm belongs to the, he said the cameras sinus is most dangerous, more complex. Because there is no, the aneurysm is not like the giant aneurysm or ICA bifurcation aneurysm. I think you needed to worry about the perforators. For type 2 or type 3, the fenestrate is so easy. And the ophthalmic artery sometimes is difficult because you is facing toward your optic field, and so you are worried about the intraoperative rupture of the aneurysm. So I think you operating so carefully, it's okay.
All right. And my other questions is about the time, because maybe my experience, I think in my country, like in Africa, most of the cases always arrive when like the symptom is more worse than the time, because I have been seeing in most of the cases in China, most of cases, some of them, they don't have even like any symptoms. But in Africa, most of the patients arrive like so late. What you suggest for someone who having more experience like yours to approach this kind of type of aneurysm? Did you think is necessary to take them even like is always late, or just perform any type of surgery for that kind of surgery case?
I think with the development of the embolic materials and the technique, and then surgery is no need for this type.
Okay.
I think endovascular is the first choice.
The first choice. All right. Thank you, Professor Shifong, and
You're
good
welcome.
topic. Very interesting for this topic. Thank you so much.
Okay, Ben.
Okay, thank you. Thank you for all the three speakers. And this is a very successful webinar again. And tonight we already have more than 1,123 viewers. Yeah.
Great. A great session,
So,
Ben.
Yeah,
Do you want to wrap it up now, Ben?
Yes.
Okay, very good.
Professor Tao. Yeah.
Actually, we have a last question from
I'm sorry.
another.
I'm sorry. Go ahead.
Okay.
Dr. Ma. Actually, he's right here. Why don't you just ask by yourself about CUSA better than diamond drill for ACP removal?
Yeah, I think, hello, this is Lima from Chenton Hospital. Because I'm a junior, so I just asked my question on the panel. So I think Professor Xu has all answered one of my question. And my last question is, any comments on the intra-aneurysm embolization? If there's some embolization already in the lesion, so will that cause some effect on or when we choose to clip it? And also, do we need to evaluate before the surgery about the calcification of the aneurysm neck, especially for the pericleanoid aneurysm? Thank you.
Yeah, thank you for a good question. And CUSA is good. It's good than the high-speed drill, especially for if you have not too many experience of the removal of the anterior clinoid process. But sometimes I think CUSA to remove the lateral aspect of the ACP sometimes is difficult. So I would like use to the drill to remove the anterior ACP, and to remove the 视柱那个叫什么呢？忘了。OK， 算了 ，OK， 不说。
column, yeah.
Obstruct. I think the CUSA sometimes it's also difficult. So I would like to use Dreer. And aneurysm embolization, I introduced in our treatment strategy. For small and medium, we usually use, because smaller than 1 centimeter, I said the braided stent, such as the Elvis or Leo, was good. Almost no recurrence if you have the density and embolization. But for large or giant, I think the fluid diverter is the first choice. Okay. We also performed the CT scan, clipping to see if there is any calcification of the aneurysm wall or intra-aneurysm thrombosis. MR image scan should also perform. And we also performed the compression of the carotid artery. Sometimes the BOT is also need to assess the collateral circulation before the operation. Okay.
Okay, thank you.
Thank you.
Okay, Ben. Do we have any more comments, closing questions or comments from anybody?
Okay, for young neurosurgeons, normally they think the giant aneurysm was terrifying, but actually, if you get the very well proximal control of the blood flow, and if you can get the distal control at the same time, actually it's not a big deal to treat the direct clipping of the aneurysm. You can make a direct puncture of the dome and made the suction in the surgical field directly.
Okay, very good. I'd like to thank you very much, everyone. Juan Lee, Ben, especially Feng Zhu, Yingyan, and John Adler. And Juan Lee, I guess we'll see you in 2 weeks, right?
Yes.
For webinar number 4.
Yes, we can see everyone after 2 weeks, next Sunday. Yeah.
Great. A great interactive session. I think John really enjoyed it. So
Okay.
Thanks, everybody. And we'll see you in 2 weeks.
Thank you.
Thank you.
Yeah, see you in 2 weeks.